Okay, welcome everybody. I see people coming in from the chat. We're going to get started because we have such a full program this evening. We're thrilled to have two top experts in the cancer field joining us this evening for our topic, Unpacking Breast Cancer, Understanding Stages, Common Types, and Rare Forms with Dr. Elisa Port, Chief of Breast Surgery at Mount Sinai Health System, and Dr. Thomas Buckholtz, Medical Director of Scripps Cancer Center. I'm Jenna Fields. I'm the Chief Regional Officer of Sharsheret. And tonight's webinar is the closing webinar to Sharsheret Summit, our month-long education initiative, which brings together thousands of people for virtual and in-person education all across the country. Please visit our Sharsheret Summit website to learn more and check out our exhibit corner and digital resource packets. And my colleague is putting those links in the chat for you to look at. We are grateful to our Sharsheret Summit sponsors, Merck, AstraZeneca, Novartis, Pfizer, Lilly, Daiichi Sankyo, City of Hope, Eisai, and GSK. And tonight's Embrace breakout session is sponsored by Gilead. Before we begin, just a few housekeeping items. Tonight's webinar is being recorded and will be posted on Sharsheret's website along with the transcript. Participants' faces and names will not be in the recording. And if you would like to remain private, you have the option to just turn off your video, rename yourself, or you can call into the webinar, and we are putting that call-in information in the chat as well. We have closed captioning available, and to display live captions, on the bottom bar, just click on Captions and then click on Show Captions. You may have noticed that you were muted upon entry in the Zoom. Please stay muted during the call. We will hold a Q&A at the end of the presentation, and if you have questions, you can type them in the chat box as we go, and we'll try to get to as many as we can during the Q&A. We do ask that you keep the questions as broad as possible, and we will not be answering any personal diagnosis questions. We want to remind you that Sharsheret is a not-for-profit cancer support and education organization and does not provide any medical advice or perform any medical procedures. Our full medical disclaimer is in the chat. A quick program spotlight for all of you. We do have incredible Facebook groups, whether you are facing advanced metastatic disease or you're newly diagnosed or facing increased genetic risk. So please consider joining one of our Sharsheret Facebook groups. And in your evaluation, you can click to sign up for those or reach out to a Sharsheret social worker to sign up. Most importantly, if you are currently facing a breast cancer diagnosis, please remember that Sharsheret is here for you and your loved ones. We provide emotional support, mental health counseling, and financial assistance, which are designed to help you navigate through your cancer experience. All of our services are completely free and confidential, and our contact information is in the chat. If you are a member of our Embrace program, someone who's facing advanced breast cancer or ovarian cancer, we invite you to stay on the Zoom following the Q&A for a more intimate breakout session with Dr. Port and Dr. Buckholtz. At Sharsheret, we know that breast cancer isn't just a diagnosis, it is a journey. And whether you're living with it or supporting someone who is, tonight's webinar is designed to break down the disease so you can feel more empowered on your journey. And now, before I welcome our first speaker, Dr. Port, to the screen, I'm here to welcome Elisa, who's going to share her story. Thank you so much, Elisa, for being here, and welcome.
Thank you, Jenna. My name's Elisa Shirago. I'm a survivor of inflammatory breast cancer, otherwise known as IBC, as well as non-inflammatory breast cancer. One day in July 2023, I noticed that I had pink splotches on one breast, which I thought was odd. Then a few weeks later, I noticed that the breast on that same side was now slightly larger than the other. And then my armpit and side of my breast started hurting. I figured I should get it looked into, although cancer never occurred to me. I had heard cancer doesn't hurt, etc. I did end up with a radiologist who mentioned IBC as a possible diagnosis, which is the first time I ever heard of it. In the week that I was waiting for biopsy results, I learned everything I could about IBC on the internet. I was lucky to find the website of the IBC Network Foundation, which is a nonprofit that had a wealth of patient resources and doctor resources on IBC. So that's how I learned, after getting my triple positive diagnosis, that my then healthcare system had me heading in the wrong direction. They said I'd be meeting with a surgeon in 1 or 2 months. I told the gatekeeping nurse what I had learned, that with IBC, chemo always happens before surgery. There's very strict order of treatment, and that IBC can move from stage 3 to stage 4 in a matter of weeks, not months or years, like many other types of cancer. Then I asked to see someone sooner, and she told me everyone goes in the same pool. So I started looking for an outside second opinion. I was so very lucky to find an IBC expert 20 minutes from me. Spoiler alert, it's Dr. Thomas Buchholz, who is one of the doctors you'll be hearing from shortly, or Dr. B, as we call him. He confirmed it was IBC, but he went the extra mile for me by contacting the head of oncology at my then system. That finally got them moving, and I was able to start chemo less than 3 weeks later in September of 2023. I credit Dr. B with helping save my life. I was again lucky to be able to switch my insurance and healthcare system to him and his team towards the end of chemo. And it turns out during the MRI, they found what they thought was DCIS on the other breast. So I had a double mastectomy after the chemo, and the post-op pathology report revealed that the other breast actually did have a few invasive spots of non-inflammatory breast cancer, stage 1. After surgery, I had 33 rounds of radiation on the IBC side and then 14 rounds of Kadcyla. Speaking of nonprofits with a wealth of resources for patients, I first learned about Sharsheret during chemo. They were so helpful, staying in touch, asking what they could help with. Among other things, they were able to connect me with another IBC survivor as a peer support and provided an oncology dietitian services. I now am a peer supporter myself with Sharsheret. I'm also a trained volunteer advocate with the IBC Network Foundation. I specialize in IBC education and public policy. And I'm happy to report that as of today, knock wood, I remain no evidence of disease or no NED since surgery in February 2024. So as my mentor Terry Arnold says, rare doesn't mean never. I'm so glad you're here to educate yourself about the basics of breast cancer as well as the rarer types. You never know when that knowledge might save a life. Thank you.
Thank you so much, Elisa. Sharing our stories makes such a huge impact, and we know you've made a difference tonight, and we're so glad to hear you are NED and doing well. Thank you so much. It's now my pleasure to introduce Dr. Elisa Port, who is the Chief of Breast Surgery at the Mount Sinai Health System. She's also the director of the Dubin Breast Center, a state-of-the-art breast center in Manhattan that opened in April 2011. She personally consults with thousands of patients and performs hundreds of operations each year. She's the author of the New Generation Breast Cancer book, published in 2015, which I can personally share is a required reading when we onboard new staff at Sharsheret. And her research focuses on mechanisms of resistance of triple negative breast cancer, care BRCA mutation carriers, and MRI utilization. She's a BCRF funded researcher, and she's a trusted voice in the media and sought after speaker who started off this morning with an appearance on the Today Show. It is my pleasure to introduce Dr. Port. Welcome. Thank you so much for being here.
Thank you so much for having me. And gosh, I just want to say, Elisa, thank you for sharing your story. And I'm honored to be here with your personal hero, Dr. Buchholz, who obviously shares the fight with me. It's so meaningful to hear from people like you. And I wish you only good health and happiness and so forth. And I'm honored to be here to talk more about education and how we can make sure that people do educate themselves and be their own advocates, as you were, Eliza, and saved your own life by getting to the right people like Dr. Buchholz. So I'm going to ask Sharsheret to man the slide deck, because it's almost past my bedtime here in New York, and so I'm home. So I don't have access to my laptop, my regular work computer, and so they're going to run this show for me. But what I'm here to talk about is just give you an overview of what's new in breast cancer, advances in screening, genetic testing, and treatment. And I know earlier on in the week, a lot of people heard more about screening, so I'm not going to talk about that too much, and we'll just move forward from there. Next slide. Just by way of background, I want to talk about the fact that in case anyone here did not know, it really is important to state that breast cancer is the most common cancer to affect women in the United States. There are about 300,000 new cases projected for 2025 by the end. And here's a really interesting fact to wrap your head around. If a woman is diagnosed with cancer, any kind of cancer, 1 in 3 will be a breast cancer. So it is the most common cancer that women get, and it comprises 30% of all new cancers in women. I never miss an opportunity to raise awareness that men can also get breast cancer. They make up approximately 1% of all the cancer cases and fewer than 1% of the cancers in men. So there's about 3,000 cases across America each year. Interestingly, breast cancer and cancer in general, important to know, is not the leading cause of death. Heart disease is. Next slide, please. There are many factors that increase the risk of breast cancer. Family history, as everyone knows, is certainly one of them. Next. Genetic predisposition, which usually goes along with family history, but not always. Next. Hormones are definitely important. Getting our periods early and having menopause late can definitely modulate risk a little bit. Next. We all know that abnormal pathology on a previous biopsy can increase risk. So women who've had biopsies that have shown some what I call funky looking cells, that can be a harbinger of increased risk in the future. Next. Environmental factors definitely play a role. Lastly, and of course, reproductive factors. Next visual. But the most important thing to understand is that usually the result of a person getting breast cancer is related to a confluence of these factors. And it's usually never just one thing. So that's important to know. Next slide, please. Of these factors we just discussed, I think it's important to know there are factors we can't control. We cannot control the age at which we individually develop our first periods. We can't control the age of onset of menopause, but there are factors that we can control. A choice of hormone replacement therapy, a choice of contraception. And then there are other lifestyle factors that can also increase breast cancer risk, like weight and other lifestyle factors. And then there are things that I call in between. The age at which someone has their first child compared to not having children at all or having children young or older can definitely increase risk. Nulliparity or not having any children is associated with a higher risk compared to having children later, which is associated to a higher risk in turn than having children younger. But I turn around and say, who's going to decide such major life decisions like the age of having children based on breast cancer risk alone? And I certainly wouldn't advocate for that. Next slide. So here's, in general, surgeons are a pretty optimistic group, and I'm no different. I consider myself part of that group. There are so many reasons for optimism in the world of breast cancer. I think to give you one statistic, if you look back between the year 2000 and 2010, each year the death rate, the mortality from breast cancer decreased by almost 2% per year. So if you were diagnosed after 2010, you were 20% more likely to survive compared to just a decade before. This brings us to where we are now, where the overall survival rate from breast cancer approaches 91%. And for some kinds of breast cancer, like DCIS, which we also call stage 0, survival approaches 99%. I was recently at a big surgical meeting, and one of the leaders of our group put a slide up that said, our goal is 0 breast cancer deaths by 2030. And I think we all kind of live by that credo and doing everything we can to achieve that. Next slide, please. The two main reasons that we can achieve this, and the two main reasons for optimism and progress, are: one, early detection. We have better options for detection than ever before. And two, we have better, more tailored treatment options. So these are our main reasons why we can look at those survival numbers and hope for future improvement even on that, and say realistically, we can continue that upward trend. Next slide, please. We know that mammograms detect cancers that are earlier stage and smaller. Most breast cancers diagnosed by imaging are what we call early stage. We know mammograms aren't perfect, but they do an excellent job and pick up approximately 80 to 90% of all new cancers that are diagnosed. In today's day and age, about 20 to 25% of new cancers detected, especially by mammogram, are called DCIS stage 0. These cancers are not invasive, and these are the ones, as I mentioned, that are associated with a 98 to 99% cure rate. Okay. So screening and imaging is one of the areas where we've made most progress. To zero in on mammographic technology improvements, we've gone from film screen. I started practicing at a time where women would walk into our office with literally envelopes filled with film screen mammograms. That quickly migrated to digital. And then now we're really, the state of the art is 3D. We can talk a little bit more about other things like contrast enhanced mammograms and so forth, which are newer technologies. But this is one area where we've made a ton of progress. And we also liberally add on ultrasound for women with very dense breasts, and MRI for those at high risk, which maximize and optimize our chances of picking up cancer early. Next slide, please. To go by stage, just to understand, we've already talked about stage 0, but stage 1 is an invasive cancer where the tumor is smaller than 2 centimeters and lymph nodes are negative. Stage 2, the tumor is bigger than 2 centimeters and/or there's minimal positive nodes. Stage 3 is what we call locally advanced breast cancer. This does include inflammatory breast cancer. It can also be a much larger tumor and/or much more nodal involvement. And lastly, stage 4 is when the cancer has spread to other organs in the body and is called systemic disease. It is important to know that stage 0 through stage 3 are all treatable and curable. And that is our goal with every single individual. And it is also important to know, while stage 4 is not considered curable, it is extremely treatable with long-term results. But importantly, when you look at this staging, I think it's critical to know that this staging system that we've used for years is a little bit antiquated because it doesn't include critical information that is even more important for prognosis. Next slide, please. For example, it's long recognized that breast cancer is not just one disease. There are multiple different subtypes. And the way we figure out what subtype a person has is once they're diagnosed with breast cancer, we run 3 tests on that tumor to tell us a little bit about what is or is not feeding it, making it tick, making it grow. And the 3 tests we do, which most people in the breast cancer world have heard about, are called estrogen receptor, progesterone receptor. Most people know that estrogen and progesterone are hormones, and together those tell us if hormones are feeding the cancer. And the third test that we do is something that many people outside of the cancer world have not heard of. It's called HER2/neu. Okay. And HER2/neu, when it's amplified, is sort of its own tumor type. So if you go by subtype, Hormone positive, HER2 negative is the most common subtype of breast cancer, making up about 60 to 70% of all new invasive cancer diagnoses. HER2 positive disease, whether it's hormone positive or hormone negative, makes up about 20% of breast cancers. And the third type is called triple negative breast cancer, okay, which makes up about 15% of all breast cancers. And that's when both hormone receptors as well as the HER2 receptor are all negative. And what's really important is separate from stage, the treatment approach is customized and tailored to not only the stage, but also the subtype of breast cancer that a woman might have. And this is where we get in these situations where people say, I'm coming to see you. People say this to me all the time because you took care of my friend and she had stage 1 breast cancer exactly like me. And I look at the two cases and I'm like, oh my God, these couldn't be more different from each other. And this is where that individualization and tailoring really comes into play. Next slide, please. So for hormone positive, HER2 negative breast cancer, which again is the most common kind, there have been better treatment options developed, but also it's important that we've also done a huge amount to de-escalate treatment, which we'll talk about in a minute. Up until about 15 or 20 years ago, chemotherapy was given very indiscriminately to this group without knowing if it was even effective. We know that this group gets anti-hormonal medication, and so we didn't know if chemo provided any benefit beyond that. Flash forward to about a decade and a half ago, when a test was developed by a colleague of mine, actually at Mount Sinai, named Joe Sperano. Joe Sperano is a medical oncologist who developed a genetic profile. It's called the oncotype, which is now the standard of care. And what the oncotype is a tumor profile where we send off a piece of tissue from a person's primary cancer from the surgery to a lab, and it spits out a score of low, intermediate, or high risk for recurrence. Based on this oncotype, fewer women are requiring chemotherapy based on their own profiles and from the data from this trial. It's true some get chemotherapy who otherwise would not have. Occasionally we'll discover a person with a very small cancer that we never would have otherwise treated. But overall, I think it's important to know the net result is a reduction in giving chemotherapy by approximately 30%. And more importantly, these women enjoy the same prognosis. So they do great without the chemotherapy as well as they would have with it. Next slide, please. And if you'll pay attention on this graph to the green line, the green line shows you that between 2004, 2005, and 2015, this is chemotherapy utilization after the oncotype was implemented. If you had an oncotype, your rate of getting chemotherapy went down from 30% to 20%, which is an overall 1/3 reduction. Next slide, please. So I think what this gives you an example of is, I always say progress and treatment. Everyone thinks progress and treatment, and progress is always better treatments, stronger treatments, faster treatments, more aggressive treatments. Progress and treatment is not always longer and stronger. As with the oncotype, it's led to less need for chemotherapy. And there are additional examples of us being able to dial down treatment and use less invasive, less extensive approaches while achieving the same results. And the theme for this is called de-escalation. And it's being done on every front, radiation, surgery, et cetera, as I'll show you in a moment. And I think this is something to be really proud of. I'm a very big debunker of conspiracy theories, but I think one of the biggest conspiracy theories that makes me crazy is people saying out there, of course surgeons want to cut more. Of course medical oncologists want to give more chemo. Otherwise, they're out of a job. It's medical oncologists who led the charge to decrease chemotherapy receipt. It's surgeons who are leading the charge to reduce the amount of surgery we do. It's radiation oncologists who are doing the same in their field. And I think that's really important to know. Next slide. So, for example, in the radiation front, it used to be a package deal, automatic, absolute. If you had a lumpectomy, radiation was given, and usually it was 6 weeks. And that was true as recently as to when I started practicing about 25 years ago. Now, clinical trials have shown that with small, favorable cancers in women over the age of 65 or 70, radiation is not always needed, and the recurrence rate could be as low as 10% compared to just under 5% with the radiation. So, not a huge advantage. We also have de-escalated lengths of treatment. Nowadays, most women get 3 to 4 weeks of radiation compared to the 6 weeks. This can make a big difference in terms of travel time, etc. There's also other types of treatment called partial breast, which can take 1 to 2 weeks, and another kind called IORT, intraoperative radiation, where, believe it or not, you can actually receive your radiation at the same time of the surgery, two for the price of one and done. And so there's many more options than ever before, and there's truly no one size fits all. Next slide, please. And lastly, on the surgical front, radical mastectomy used to be the standard of care. This has evolved into simple mastectomy, nipple sparing mastectomy in many cases. And in some practices now, up to 50% of mastectomies performed are nipple sparing. So a huge, huge advancement in dialing down the extent of surgery on the mastectomy front. And obviously, many women choose for less surgery for lumpectomy, and it's approximately 60 to 70% of women who can have a lumpectomy choose that option. Up until 2023, it's important to know that almost all patients with invasive cancer underwent simultaneous lymph node staging. Many of you have heard of this procedure called sentinel node biopsy, where we inject some dye into the breast. It travels to a couple of the nodes. We make a separate cut under the arm, take those out to check for node spread. 2023, a trial was performed in Europe called the SOUND trial that showed for selected patients, usually 2 centimeters and smaller, favorable profile again, age 52 and greater. That's who was in the trial, but in the trial, it was usually women. The average age was 60. There's absolutely no difference in survival or recurrence rates without the sentinel node biopsy. So we're even on the surgical front, we're scaling down and allowing patients to omit the sentinel node biopsy, which up till 2 years ago was really an automatic. Next slide, please. So in summary, survival rates for breast cancer are better than ever before, with expected improvement owing primarily to early detection and better treatments. But I would love to always make the point that in order to benefit from early detection and better treatments, you have to do those things. Women have to get their mammograms. If they're told to have radiation, they should do that. If they're told that they need tamoxifen for 5 years, stopping that early is going to affect potentially outcomes and so forth. Research has led to better options than ever before, but it has also led to de-escalation of therapy and surgery in many cases without compromising survival. And I think that's something to be hugely proud of. Thank you so much. I've really appreciated the opportunity to share this with you.
Thank you, Dr. Port. That was just phenomenal. I learned so much from your presentation, and I really appreciate how optimistic this feels. And I'm sure I reflect that gratitude for everyone joining us today. So thank you so much for this. It is now my pleasure to introduce Dr. Thomas Buchholz, who is the Medical Director of Scripps Cancer Center, a comprehensive and clinically integrated cancer care program in San Diego. In his role, he's responsible for directing all clinical activities and programs at Scripps Cancer Center, ensuring care is efficient, effective, and supports the patient-centered mission of the program. He leads the development of clinical research activities within and is and has collaboration with clinical trials and other industry-sponsored and investigator-initiated trials. In addition, he maintains a clinical practice focused on radiation oncology and breast cancer. And prior to his role here, he spent 20 years in Houston at the University of Texas MD Anderson Cancer Center with leadership roles, including division head and department chair of radiation oncology, and served as executive vice president and physician in chief. Welcome, Dr. Buchholz.
Thank you, Jenna. What an honor it is to be here. First of all, Dr. Port, fantastic talk. It's a pleasure to share the stage with you. I've always wanted to be on the Today Show. I've never achieved that professional achievement. Congratulations. And to my friend Elisa, thank you for sharing your story. It's fantastic to see you here with your long hair. I remember it was like yesterday when we first met. And thank you, as Dr. Port mentioned, for being your own advocate, teaching us that it's really important to seek out care from those that need it, not always get caught up in the bureaucratic system. And I was happy that I was able to reach the oncologists there in your healthcare system and get them going and get you on the right track. But thank you for now, like many others, to use your own experience to help make a difference for the breast cancer patients all over the world. So keep doing it. Great news. Well, I'm going to continue to share this optimistic story. I mean, it is such a fun time to be a breast cancer provider. It's such a privilege. I think Dr. Port and I share a lot in common. You know, people say, is it hard to be an oncologist? It's really a privilege in so many respects. We get to meet wonderful patients like Alicia and intervene with them and help them along their way. But it's also an exciting time to be a doctor because the death rates, as we heard, continue to drop every year. And in doing so, it's a result exactly what Dr. Port said of early detection and getting the best treatment. But the treatments are advancing at such an exciting rate. I mean, every month almost, there's a new breast cancer therapeutic. Every meeting that Dr. Port and I go to now, we're hearing about a new randomized trial that's changing the practice and standard of care. So across all the subtypes, we have new therapeutics, and each one of them is providing incremental advantage over the best standard of care. And here's these mortality curves that Dr. Port referred to. This is from the American Cancer Society. And you can see right around 1990 or so, just in general, all these curves of people dying from breast cancer have gone down year after year after year. Now, I know that a lot has to do with public education, making people aware of breast cancer. In the 1980s, probably it was less common. The importance of mammographic screening, the importance of new therapeutics. But what else you might not know is this is right around the time that both Dr. Port and I started practicing in the field of breast cancer. So not that that necessarily led to a change in national statistics, but just an interesting coincidence. I'm just kind of joking on that. But I think what is reflective of this is actually that we got to participate in this era of breast cancer where we've been a witness to and participant in just a remarkable change in outcome. And it's so rewarding to be a physician during that time course. And here are the statistics just shown. As mentioned now, the probability of 5-year survival in the United States for a diagnosis of breast cancer, which again, back when we started, we could just see a precipitous increase. And it's so exciting. And we have every reason to be optimistic. And still yet today, when women are diagnosed with breast cancer, the first thing that crosses their mind is, oh my gosh, I might die of this disease. But the probability is that they're going to have excellent outcomes. Now I was asked to talk about less common but important breast cancer diagnoses. And it's important because breast cancer is not one disease. Dr. Port very eloquently alluded to this, that we consider a number of different things when people says, what type of breast cancer do you have? We could break up breast cancer in a variety of different ways. What does it look like under the microscope? Most breast cancers originate in the ductal system that carries the milk from the producing milk glandular units called lobules towards the nipple. And that invasive ductal cancer is commonly one of the most standard of care. There's another type called lobular cancer that I'll mention in a little bit. But in addition to histology, we look at the individual cells. Those are called grade. Some cancers look highly malignant. We could actually see them dividing right under the microscope. We could see things called mitosis. Other cancers look kind of bland. They blend into the normal tissue. And so a low-grade cancer and a high-grade cancer act biologically too differently. And then these biological markers that both predict for outcome and also response. And the three most common are this estrogen receptor, progesterone receptor, and this important oncogene called HER2. And all these sit on the surface of the cell and again stimulate the cell towards growth. So these are all cell surface receptors. And then there's also a type called inflammatory breast cancer that Alicia shared her story, which is a fortunately very uncommon form of breast cancer, and it has a different biology and a different presentation, and it has a different aggressive subtype. So it's not easy to answer what type of breast cancer because there's a whole variety of ways to describe it. Here's just the American Cancer Society. You might also hear these terms that sometimes are incorporating the hormone receptor status and the HER2 status. So these luminal A, luminal B are now coming into the vernacular of breast cancer, the basal-like. So sometimes you hear ER positive, HER2 negative. It's also sometimes referred to as luminal A, and that's the most common form of breast cancer, again, 70%. And this triple negative is sometimes called basal-like cancer, and that's 10 to 15%. And then the HER2 positive cancer, again, also about 10 to 15% of those. And these things are important because the doctors, the teams, the surgeon, the medical, the radiation oncologist working together all incorporate these biological factors into decisions concerning treatment. And they also predict what is the responsiveness to chemotherapy, what is the responsiveness to radiation, what's the responsiveness to hormonal therapy. And so all of these things are important considerations. So let's talk about some of these less common forms of breast cancer. You might hear of a lobular breast cancer. Now this is, again, just a cartoon depiction of the breast. And the milk-forming units are called lobules, and these ductal systems, kind of like drainage duct, bring the milk to the nipple. And most of the breast cancers form at the end of the ducts, called the terminal ductal unit here. And that's usually leading to an invasive ductal cancer. But in about 10 to 15%, they actually occur in the lobules. Now, overall, lobular cancer and ductal cancer both can be highly cured. Both carry an excellent outcome, but they are a little different biologically. And some of the difference I'll highlight here. So some of the unique features of lobular breast cancer is it doesn't really grow as discretely into a mass. Usually you think of a cancer cell starting in a nidus and growing outward and forming a mass. Well, a lobular cancer forms, like is shown in the pathology slide down below, in little tentacles. And so it more interdigitates with the normal breast tissue. And accordingly, it makes it harder to detect on imaging. It's less reliably detectable on usual mammogram and even ultrasound. It's hard to see the extent of the disease without actually looking at it under the microscope. And so it makes it a little bit tricky, and we might more commonly sometimes use an MRI scan to help elucidate that. But it doesn't necessarily preclude us doing breast conservation surgery. It doesn't preclude us to treat it in pretty much the same fashion. On the good news, lobular cancer is almost always in this favorable hormonal prognostic category of having this ER/PR positive. It's pretty uncommon to find a triple negative lobular cancer. And the treatments and the outcome is pretty much similar to invasive ductal cancer. But it's just an unusual, but not really rare common, it again makes up about 15%. Now this other form of cancer is called triple negative breast cancer. This has become, people are more aware of it because it is a more aggressive subtype of breast cancer. It too makes up about 10 to 15% of all breast cancers. And it's determined not by the finding of a positive marker, but by the lack of 3 markers. So it's easier to say this thing's something because it has this, but it's harder to say because it lacks 3 things. You'd like to find it and identify it because it had a positive marker. And accordingly, the triple negative really isn't one disease either. I think we're going to continue to define different categories of triple negatives. They're probably not all the same amongst the triple negatives. So it's a more diverse subcategory. And there's likely many types of triple negative breast cancer. There's some unusual types of cancer like squamous cell carcinoma of the breast. That could be a triple negative, but there are other ones that are more like breast cancer. But in general, it tends to be a little bit more aggressive than ER positive breast cancer. Aggressive meaning it's a little bit more frequent to have lymph node involvement at the time of diagnosis. It's a little more frequent to metastasize than ER positive at a smaller tumor size. And it might have an association. Most BRCA1 germline carriers, so if someone is found to have a germline mutation in BRCA1, most commonly those are going to be triple negative breast cancer. And the one finding that's most important, it doesn't respond to hormonal therapy like an aromatase inhibitor, tamoxifen, which blocks the estrogen receptor because it doesn't really have an estrogen receptor associated with it. It doesn't respond to hormonal therapy. The good news is it's more responsive to chemotherapy than ER positive disease. So there is effective treatment for triple negative breast cancer. And most people with triple negative breast cancer are going to have a combination of treatments that include surgery, chemotherapy, and radiation. And now, also an important finding just over the past 5 or 6 years is that this is the one subtype of breast cancer that immunotherapy is playing an important role. Now, immunotherapy has been a major advance in the arsenal against cancer, and that's not treating the cancer cells per se with drugs, but it's treating our own immune system and activating the immune system to fight the cancer with the chemotherapy. So there have been clinical trials now in triple negative breast cancer that have demonstrated the combination of chemotherapy in addition to immunotherapy may give a better outcome than just chemotherapy alone. And this is in addition to the surgery and radiation components. So again, another exciting advance in this triple negative space. Now, finally, the one type of unusual breast cancer that I've been passionate about most of my career that Alicia just shared her story of, and that's often a commonly unknown type of cancer called IBC, or inflammatory breast cancer. And this is an unusual, it's a highly aggressive form of breast cancer. As Alicia pointed out, it's not something to wait for a month to get into access to see your healthcare providers. It's something that we'd like to start treatment really quickly because the cancer can progress and move from stage 3 to stage 4 in a relatively short period of time if it's not treated. It also presents differently. It can occur in younger patients. Indeed, one of the people who have joined the call today, I met as a 20-year-old, I think, or 20 or 30-year-old. I met her when she was just there as a young mom with a very young child. And she presented, not thinking about breast cancer in her 30s, and presented again with this unusual presentation. It's not something that's picked up by mammogram, but it's really something on the surface. The skin becomes red, inflamed. It looks like a breast infection. And accordingly, because people are young, they go to the emergency room or the primary care doctor and they're treated for a breast infection, but indeed it's not a breast infection. This redness or erythema is a classic hallmark presentation of inflammatory breast cancer. There's also swelling or enlargement of the breast, as Alicia pointed out. It could lead to this pitting of the skin, which is a breast edema or breast swelling. That's called by the French term peau d'orange, which means kind of the skin of the orange. And I guess if you look at it orange, you can see this dimpling appearance of this. And so the disease does involve the lymph channels of the breast skin. And it's immediately, because it carries a prognosis that's a little more serious, it's by definition either stage 3, or if there's evidence of metastasis at the time of presentation, it can be a stage 4. So all of these patients need immediate staging studies to evaluate for metastasis. All patients should be seen by a qualified, experienced multidisciplinary team that includes a surgeon, a medical, and a radiation oncologist. We need the input from the diagnostic imaging people. We need the input from a reconstructive surgery down the road. We need the input from the, our social workers and the people who put in their portacath. Everybody's got to work together, and they got to work together in a coordinated team. Now, IBC can be, as Alicia said, it could be triple negative, it could be ER positive, it could be HER2 positive. So you can see there's an interplay between different biologic subtypes can all present as IBC. And the take-home story is that treatment should be done right away. As mentioned, these patients, by definition, should receive neoadjuvant systemic treatments as the first treatment. Oftentimes, if you try to approach this with surgery first, you wouldn't be able to include a volume that safely removes all the skin necessary. And so these people typically should start on chemotherapy right away. If they're triple negative, they should also receive immunotherapy. If they're HER2 positive, the chemotherapy should be combined with an anti-HER2 drug like trastuzumab and pertuzumab. After systemic therapy, all the patients should have surgery. The surgery should be a non-skin sparing mastectomy. These aren't the type of patients where we like to spare the skin in effort to get a better reconstruction. Because the skin itself is a harbinger of where the disease is, the skin has to be removed with a mastectomy with a primary closure. They should have a standard lymph node dissection. And I'm a big fan of de-escalation. As was pointed out by Dr. Port, this has been remarkable how we've been able to shorten radiation course and treat to lower dose, but for IBC, we don't. IBC, we pull out all the stops because it continues to be an aggressive thing. And reconstruction is delayed until after the treatments are all done. And it's not just the patient. Again, I think in breast cancer in general, we have to be also involving our nurse navigators, our social services. Here at Scripps, we have a wig bank. We have our nurse navigators. We have rehabilitation to minimize the risk of lymphedema. We have support groups like our friends here tonight are offering educational classes, integrated medicine, and more. And I mentioned my colleague Junaid Babora is joined here, and she was a young 30-some-year-old with a 2-year-old. I treated her back in Houston way back in the day. And just last week, she came out and visited me here in San Diego. And you know what we did? We talked about that daughter's wedding. That little 2-year-old girl who just recently got married, and she took this selfie with me. I can't imagine what anniversary that was, but that was over 20 years ago. So again, just ending on an optimistic story. And I'll end again with another patient I had the pleasure of working with. This is another typical patient that just highlights how far we've come. A single mom in her 40s, a 13-year-old daughter. She's a soccer mom. She's traveling the whole San Diego County every weekend. She works at Google. She feels a breast mass. And when I saw her, she had advanced disease. She had a 7-centimeter tumor, multiple positive nodes. And again, the importance that you're seen by a multidisciplinary team where you have the expertise of medical and radiation and surgery all working together gives these types of happy outcomes. And here she is here in the beach of San Diego. I always meet people as they're just growing back their hair from chemotherapy. And so she finished her radiation. And just a shameless plug, here she is now participating in this movie that we're helping to promote. It's kind of another nonprofit called Conquering Breast Cancer. It's being produced out of Australia and New Zealand. And Carrie here looking very elegant and so this is something maybe someday, Jenna, you could show this movie or distribute this movie. And the only thing I'm getting out of this movie, I made them promise if I participate that I get invited to the after party at the Cannes Film Festival. So please vote it to get a Cannes award. I think it's going to come out next year. They have one already out on conquering cervical cancer that I watched, and it was really exceptional. So with that, thank you very much. What a privilege it's been to participate in your thing today. Do I stop sharing? No.
Yes. We'll have you stop screen share. Thank you so much, Dr. Buckholz.
Share.
And if I can just say, between going on the Today Show or being at Cannes, we hope something happens in terms of your dreams coming true this year. Um,
Right.
we'll try and help make that happen. We're gonna now open it up for questions. That was exceptional and so much great information, and thank you so much. I know that everyone on this call is so appreciative of both of your expertise. We're going to open up for questions. A few questions have already come in the chat, and I'm just going to ask, as you add questions, to keep them as broad as possible, and not to ask any personal diagnosis questions. So I'm going to start with immunotherapy, because there's a lot to unpack there if you want. What determines if a patient undergoes an immunotherapy, and who does?
Well, we determine it on the basis of clinical trials. And so the combination of immunotherapy and chemotherapy, so it's not replacing chemotherapy, but it's in addition, has been shown to improve outcome when given before surgery for patients with more advanced triple negative, so stage 2 or 3 triple negative breast cancer, and in the setting of metastatic disease as well. So there's a lot of new treatment approaches now in the studying of stage 4 disease. I should say both Dr. Port and myself are not medical oncologists, and we should caveat that, right? And we certainly don't want to profess that we have expertise in systemic treatments, but obviously we work closely. Now, we just published an article in the Journal of Clinical Oncology of looking at the data of using immunotherapy in ER positive disease. And it looks as if there is some promise there. I think there's still more work to be done before it's kind of approved by insurance, et cetera. But Dr. Port, do you have anything else to add?
No, I think you summarized it beautifully. The only thing I would say is that, the excitement about immunotherapy in triple negative is it was the one type where we really had very little to offer. So the fact that, the trial, just so everyone knows, was called the big landmark trial, was called the Keynote trial. And the fact that it showed a benefit in coupled again with chemotherapy, not in lieu of, was incredibly, again, a source of optimism for us, because this is the specific kind of cancer where we needed more options, and now we have them.
Dr. Port, I'm going to ask you about your slide deck. Someone acknowledged in your slide, you talked about how early periods and menopause can have an impact on developing breast cancer. Can you expand on that, and then just
Sure.
address the debate around hormone replacement therapy after successful treatment of ER/PR positive?
Yeah, I think that what's really, hormones are complicated. I think what people need to understand, the prevailing understanding, is the more cycling that you do, the more your risk is increased. So if you start your period earlier, and remember, there's some data that, like, in the 1800s, the average woman got her period at like 17. And then in the 50s, it was like 13. And now the average age that a young woman gets her period is now 11.9. And I know that doesn't seem like a big difference, 11.9 to 13, but that means there's a lot more younger women getting their periods, even younger, very, very early onset puberty, we call it 8, 9, 10. And so the more you're cycling, the more you're cycling, the more cycles of hormones your breasts are exposed to. And obviously, the more delayed menopause is, the more cycles you're getting on the back end. One of the reasons why pregnancy is thought to decrease the risk of breast cancer is purely theoretical, is that it interrupts those cycles, which is weird considering that during pregnancy, obviously, you have lots of estrogen on board. So it's not so much the quantity, it's the cycling. As it relates to, you had asked about, hormone replacement therapy. Sure. I mean, if there's an increase in hormones, obviously hormone replacement therapy is given postmenopausally. So what it's saying is when your body's stopping to make hormones, you're adding that back. And so there is a small added risk with the combination of estrogen and progesterone. It's a very marginal risk. And from my standpoint, for patients who don't have breast cancer themselves and who don't have a hugely high increased risk, I would not discourage someone from going on it. I think the added risk of 1 or 2% is really not so profound compared to the profound benefits that women derive from this when they're really suffering from a menopausal standpoint. It's interesting, estrogen alone does not really increase the risk of breast cancer by much. The problem is that estrogen alone, what we call unopposed estrogen, increases the risk of uterine cancer. So you don't, it's kind of a catch-22. You don't want to take estrogen and progesterone to increase your breast cancer risk, but you don't want to take estrogen alone to increase your uterine cancer risk. And so hopefully there have been some newer options that have been developed that really protect the uterine lining and so forth. That's what I would say about hormones and cycling. Tom, did you want to add anything to that?
No, I think that was beautiful. That's great. I mean, one striking thing, I think the last time the American Cancer Society every year publishes their data, and it comes out, and then Dr. Port gets invited to the Today Show, and I get invited to the local newscast here in San Diego.
You're
But
going to con, my friend. You're going to con.
oh, that's but
We're very
but,
optimistic. You're
you
going to
know,
con.
one of the buzzwords this year was that breast cancer is increasing in the younger population too. And I think, as Dr. Port mentioned, one of the things that has been a social change is this age of first child. And I think that's some of these things like the early menopause and the delayed child rearing that's a part of our Western culture now are factors that can increase the risk of breast cancer. And you could study things in animals too, and you could induce false pregnancies in breast cancer models and prevent breast cancer from happening, right? And there's some theory like, oh, should we take 10 to 12-year-olds in the United States and induce a false pregnancy just through hormonal manipulation and prevent them lifelong for breast cancer? Now, that's not a trial that will ever be done in the United States, but you could do that in animal models and really show that these are real effects that affect the breast health.
Yes, definitely. And I feel like I should make a plug for our recent webinar we did on hormone replacement therapy and the options available right now for patients. So maybe we can find that and put that in the chat before this ends in the next few minutes. One last question. I'm sure I know from so many of the patients we talk to that fear of recurrence is always on the mind. There's a question about what are factors that, or what are behavioral changes that folks on this call can make to reduce their risk of reoccurrence?
Get the best treatment up front, right? That's probably very important. And then follow. I think the other thing, the things that are within people's control is weight management and healthy diet and exercise. I think for people who have significant weight gain, that's been an independent prognostic factor in terms of probability of recurrence. So that's something that continue to lead a healthy lifestyle. Alcohol consumption is not a risk for recurrence per se, but it can contribute to the development of new breast cancers in people who've had a breast cancer. But I think probably weight is the one thing that I'm aware of that is potentially within people's control.
Dr. Ports, do you want to add anything?
I mean, sure. I think that, that I couldn't agree more in the sense that, we're a country now where 30 to 40% of our population is obese or overweight. And I think what's really concerning is that you're seeing these obesity rates even in the younger population, in the 12 to 19-year-old age group. Apparently, up to 20% of our children are overweight or obese. And so, if, as Dr. Buchholz correctly said, that weight is a factor for both development of breast cancer and breast cancer recurrence, these are the things you start putting them all together, and we're wondering why we're seeing breast cancer in younger women, and that can also be another factor. So I would just take off on what Dr. Buchholz said, is like every small thing, like weight may be a small factor. Deciding to have children later as a lifestyle choice and a professional choice may be a small factor. Women getting their periods younger may be a small factor, but now you compound one on top of the other and the other, and all of a sudden you're starting to see these noticeable upticks in breast cancer in young women. And I think it's a confluence of factors.
Yeah, no, I appreciate you sharing. And I should also make a plug for our free nutrition education. We do have programming available for nutrition support for patients currently going through treatment and in survivorship. So please reach out to us about that program as well. That is the end of our main education this evening. Thank you, Dr. Buchholz, Dr. Port. This was really exceptional. So much wonderful information. As we wrap up, I'm going to ask my colleagues to put our evaluation in the chat so that those participating can give us feedback and we can help improve our programs and provide more for what you're looking for. We are going to turn it over in just a minute for a more intimate breakout session with Dr. Port and Dr. Buchholz for our Embrace community. Those are those facing metastatic breast cancer or advanced ovarian cancer. We ask that only that population stays on for this intimate breakout session. For the rest of you, we want to thank you for joining us. Thank you to Elisa for sharing her personal experience. And thank you to our Summit, Sharsheret Summit sponsors. This is the end of Sharsheret Summit, our last webinar of a month of education. We want to thank Merck, AstraZeneca, Novartis, Pfizer, Lilly, Daiichi Sankyo, City of Hope, Izai, and GSK. And tonight's breakout session for Embrace is sponsored by Gilead. Please remember that Sharsheret is here for you to support you through this experience. My colleagues are putting the information in the chat. And once again, we're going to add our survey for you to take as you're logging off, unless you are an Embrace member, someone who has metastatic breast or advanced ovarian cancer. And you're welcome to continue to stay on for just a little bit longer to have more of your questions answered by our experts. Thank you again, and good night, everyone.